In my assessment part or over these presentations, I just want you to give you a basic concept related with. I'm not going to teach you this is spastic, this is diplegic. That's the different part. That's more look like a theoretical part in terms of understanding the cerebral palsy. But today we are more discussing about the different scales, how to classify that particular CP child in which category clinically. And other than that, we'll try to teach you related with the assessment format which we are using in our clinical practice and how to write. Because this webinar is mainly designed for the students who are like the final year and toward the internship, or they are doing their internship, and the other professionals which are clinically doing their practice. So. Before starting, yes, cerebral palsy, we all know it's a big term. It's an umbrella term actually, and whenever it's related with its definition, as a physios, we always consider the motor part. There's a movement and posture problem, or the component which is related with their motor control or the postural control is creating the problem. But overall, there are many other things also, like related with the perception, the sensory disturbances, and the vision issues. The epilepsy is a huge problem in children with cerebral palsy. So these are some comorbidity factors which affect our treatment also, which affect the prognosis also. So before giving a diagnosis, I think there are many cases where we have to be very careful before writing down, yes, this is the case of CP, because most of the time I have seen, even in terms of neurologist assessment, I have seen we are very really in hurry to write down the CP whenever child is having motor component issues. But sometimes we need more assessment, especially the history taking part. That is very important to classify, because it's not like if a child is not walking, not sitting, or having any kind of developmental delay, he or she is a case of cerebral palsy. Sometimes it is not. So the kids may have sensory developmental issues. The kids may have epilepsy problem, which is very common. So in childhood or in pediatric population, it is very common, or most common physical disability. It's maybe the prenatal issues, it's maybe the natal issues or the postnatal. And definitely whenever I have any kind of history which is related with high risk, or related with any kind of developmental or the delivery related any complication, definitely those are the population which are toward the higher risk for the cerebral palsy diagnosis in future. So those are the kids which really need good supervision in terms of early intervention program. As we know, this cerebral palsy is mainly denoted for the movement disorder, but yes, it's not only the movement issues, but there are some other problem also which may be related with the development. So just imagine if my neck control is not there, or if I am having poor neck control, it's not necessary. It's only because of delayed development or the delayed milestone, but it's maybe related with vision. So that's how I just want to give you one example. If we are talking about neck control, so it's come around 3 months or 2.5 or 3 months. So when we are talking about the neck control, which is like a very early indicator for any kind of developmental delay. So kids usually around 2.5 or 3 months, they can recognize many colors. So they are looking here and there, and that's how they try to look for the new things, or they are searching for something new. So that's how the neck muscles are getting developed. So the reason it's somewhere, it's related with sensation. That is the vision, that I am looking here and there, and that's how I'm searching for the, sometime it's a colorful toy sometimes. So that's how the color recognition and perception develop after 2 months of age. And that's how the neck control or the neck extensor start working. And that's a sensory part which is coming first, and then the motor. And that's how it can be vice versa. If a child is having motor developmental delay, like in cerebral palsy, definitely he or she is not able to extend his head or raised his head, so he can't look properly the things. So that's how the secondarily visual issues or the distance in terms of his gaze, in terms of his depth perception, everything is going to be having some problem with development. The meaning for this, I'm just saying, in our assessment, we have to be very careful whether it's a sensory based motor dysfunction or motor based sensory dysfunction, because that's how, if my reason is something else, like if I always speak whenever I'm speaking about the sensory webinars or something which is related with sensory processing issues, I always talk like if you have any kind of motor component issues, definitely somewhere we as a clinician have to think about the sensory development. So, and if we have any kind of behavior issues, so definitely somewhere we have to think about the part which is related with the sensory development, because that's how we want to know what's the reason why the child is having this kind of behavior, why this child is having this kind of problem. And that's very important, because we all know that's how our development, if we talk about development, the reflex development was there initially, then we controlled it with time, that's more integration. So reflex is somewhere like one sensation, then toward the higher center, and then the motor output. If my motor output or the motor control is somewhere affected, definitely somewhere I have to think about the sensory component also. So that's how there's a difference whenever we are treating a child. Tomorrow I am going to teach you some basic skills or the basic treatment strategies, but somewhere that's all related with cerebral palsy. I'm in these 2 days I am only and only talking about the kids with cerebral palsy. But if it is not a case of cerebral palsy, yes, definitely there's some changes in our strategies. Related with, we all know as a students as well as the clinician, there are many people who are running behind like the history related with cerebral palsy. Usually we call this cerebral palsy as a Little's disease also, because specifically the diplegic cerebral palsy, and that's the name of that particular person. Risk factor which is there related with, I think some marker is coming on the screen, is it?
Blue line, huh?
There are some blue lines which is coming over the screen. I don't know, it is visible to me only or it can be with everyone. I don't know why it is coming there. So related with the risk factor, whenever there's some risk factor, it's important, because if we are taking history, that's the first part of our assessment. Mostly we so whenever we are talking about the assessment part, definitely the history is very important. Why history is very important? Because if there is a suggestive history of related with any kind of developmental damage to the brain, either at the time of gestational period, that is like during development, intrauterine development, at the time of birth, or maybe within the 2 years or 2.5 years of the life, early life. And the risk factor, these are also important, because these are the not causes for CP, but these are the risk factors. So the kids may have some problem in future. So if there is a history of premature birth, the low birth weight, any kind of diabetes problem to the mother, or any kind of infection like the torch infections, these are the some risk factor which always has to be asked in during the history taking part of our assessment. Why it is important? Because the developmental part is different. Like the kids who are just born with a mother having some kind of torch infection, definitely they may have microcephalic presentation, they may have some kind of IQ problems, they may have behavioral problem also. So the kids who are like premature, usually premature kids who are like diagnosed with cerebral palsy, not for all, I am talking not for all premature. I already said prematurity is a risk factor, it's not the cause for cerebral palsy. So just imagine if I'm getting if I have a child with the diagnosis of cerebral palsy where the history is somewhere related with the premature birth. So premature birth, it's early birth or the before completion of the 9 months. So definitely somewhere the myelination part or the brain development is not completed. And also at the last part of our pregnancy, like the around the 8 months, usually the deep cells of gray matter, that's the part which is on the peak of the development. So we have to correlate somewhere. If we have any kind of connecteris history or any kind of neonatal jaundice, And if kids are presenting with diagnosis of cerebral palsy, definitely we have to check. We have to check the vision system and the auditory system, because most of the kids who have history of jaundice, neonatal jaundice or connecteris, if they are present or diagnosed with cerebral palsy, they usually have dystonic presentation and having some visual and auditory issues also. So if these kind of histories are there, we have to correlate our history as well as the clinical presentation. So we are going to talk about the assessment part. Why it is very important, what we have to assess in kids with cerebral palsy. I think the ICF model is the best thing, which always talk about any kind of disability, any kind of functional problem, or any kind of developmental, everything is there in ICF framework. So whenever we are talking about cerebral palsy, definitely the ICF format will be more evidence based, will be more about explanatory, will be more about the discussion, will be more about the coding, will be more about the compensations for the any kind of insurance. So everything is available if we are going through the ICF model. And as I am NDT certified, so definitely we always follow the ICF model, because this is the one framework which give you lots and lots of idea for one particular situation. It's not only with the CP, but with any kind of diagnosis or any kind of disorder which is going to be classified under the ICF framework. So and it's valid, it's reliable, it's worldwide useful, and we can be like, we can write down any assessment if we are using ICF for any kind of health professional. What's the aim? Is it audible? Can anyone just give me a feedback? Is it audible?
Yes.
Okay, thank you so much. So the aim of ICF, definitely it's designed for various disciplines, is designed for all the health professional. It's talk about for everyone, because it can be used for comparison, it can be used for prognosis, it can be used for explanation to the policymaker, to the individual families, to the disability person, for any kind of disability act and insurance. Everything is there if we are using the ICF model. It can be used for a statistical tool in our research paper. We can use it. We can use it as a clinician also, for the educational purpose also, everything. So that's what the ICF model is very important before understanding the assessment. So this is actually the one slide which I really want to understand. So like there are some factor which is mentioned, like the body function and structure, the activity, the participation, the environmental factor, personal factor, and the health condition which is on the upside. So before going toward the cerebral palsy, I'm just giving one simple example. So if imagine if I had any fracture or any kind of fracture of like just imagine if I have femur fracture. So definitely what I have to write in disorder or disease, it's a femur fracture or any kind of so we are talking, it's a fracture, and in body function and structure we'll write down about the particular thing, it's a femur fracture, and then we'll go toward the activity participation. So if we are going to talk about CP or the cerebral palsy, how we can describe about this thing. So just imagine if the health condition or the disorder is cerebral palsy. What about the body function and structure? We'll talk about the brain or the brain structure which got damaged during that particular time, like maybe the hypoxia or something like that. So in body structure and function, we'll write down about the damage in this, damage in this, that. And in activity, these 2 points are very, very important before writing down any assessment: activity and participation. See, most of the time, whenever we are dealing with any kind of neuro patients, specifically like the CP or any kind of other neurological patients, definitely it's take long time to understand this. Like there is some changes with therapy and how long it will take. Usually the people ask or the parents ask, when he will start this thing, when he will do this, that. And definitely, I think if I am very sure in terms of my assessment, I can explain you anything, anything. Even if I am at the end, I will show you one of my assessment part. And if you will ask me, I think if I know about this ICF component, definitely I can explain you anything. Why I am telling you all these things? Because this activity and participation, these two terms are very important to understand. When we are talking about activity, we have to always consider about the individualized or the individual function. So like if I can eat, I can drink, I can walk, I can run, I can sit. So these are the activity. It's more talk about the functional part. So like imagine if as a young students, whenever we are treating any kids with cerebral palsy, it's very easy to find out, oh, he's not able to sit, oh, he's not able to stand, he's not able to walk. But these are his limitation, his activity limitation, or he's not able to perform those things. But what about the positive part? So that's how, if I'm going to write down and I will say, oh, he can sit with maximum support, so that's your positive attitude for that same thing. But if I'm writing he can't sit independently, that's his activity limitation. But if he is sitting, but if he, even if he is sitting with maximum support, I will write down he can sit but with maximum support. That those are my qualifiers, or those are my parameters which we are working on with the help of our therapy. So I will explain you better with my assessment part. And the participation, what's the difference between activity and participation? Participation, we always consider about the social scenario or the social part. So just imagine if I'm sitting here and I, like if I'm sitting in my house, or I'm sitting with you, maybe a 2 person or 3 persons. So if I'm sitting at my house and I can take a glass and drink water, so that's become my activity because this is my function, or I am doing for my own. But if I'm sitting with you guys and 2 3 people are sitting in a restaurant and I'm able to take that glass and drink water, that's become my participation. So there are many cases, there are many things why I'm talking this thing. More of the time we feel, oh, the child is able to walk inside our clinic or inside his house. But what's the scenario in participation, or in outside, or maybe in community? Because the two pictures are totally different. One is about the limited area, or one is about the limited environment, and another one, it's about the school, it's about the mall, it's about the gardens. So definitely the functional level has changed. So activity, it's always talk about individual. Participation, it's related with society, it's related with outside activity. So like for example, like if a child is able to copy something, or like he can write ABCD sitting in front of his mother, or maybe in tuition classes, but he's not able to do the same thing in it is so, it happens. There are many parents, they complain, he's okay sir, he's writing everything in front of you, but at school he's not at all writing. What's the reason? See, reason is something different. It's about the participation. So if we are very clear in terms of participation, we can do any assessment. So we'll proceed further. What about the environmental factor and personal factor? These are the contextual factors. Actually, the contextual factor, it's about what are the factors which is present, which can be helpful for a child. So like if I have a child with cerebral palsy, and the parents are not good in terms of the economic condition or the financial condition, definitely it's a barrier. If their educational level is not very good, or they are from somewhere a village, or they not understand what's the cerebral palsy, definitely my explanation will change, or my wordings will change to explain them how to accept, how to treat, how to deal. So environmental factor may be anything. It's maybe related with the ramps or the stairs or the space, anything. So just imagine if a child is coming for you every day, a case of cerebral palsy, and your clinic or the hospital is on the second floor, and if lift is not there, definitely after some days it's become very hectic for the parents to bring their child every day. And what about the personal factor? Personal factors depend on other health issues, like our kids who are having cerebral palsy, the prognosis is not very good, but the kids who are not having epilepsy, definitely the prognosis is something different comparatively. So this is more about how to write down assessment, the functional assessment. Next, whenever we are talking about body function, we have to always consider the multi-system and single system assessment. What does it means, the multi-system and single system? Whenever we talk about multi-system, we always, what we are saying, like the like kind of observation. So like he's sitting with asymmetry, or he's taking more weight on one side, or his hand is flexed. So without touching, we are just checking how he is looking in terms of his function. We'll go further. So this is very important whenever we talk about activity and activity limitation. In all our assessment, we have to write down these two factors, the activity and activity limitation. Activity, it's always come first because that's how the positive part. So activity described as individual's function, how he is doing. Like just imagine if because I'm explaining all these things because I will explain you about different scales. So if I'm holding a bottle and I'm just holding and someone is opening for me, and then I'm using my both hand or maybe some accessory movements, and then I'm drinking water from the bottle, then how you will write down? Definitely you will write down he can drink from his bottle with minimum support or with verbal guidance, but he can. That's what I mean. So whenever we are writing for any child related with our assessment, always consider the positive presentation first. Why it is important? So after some day, if you are explaining some parents that after therapy he's able to do that, they will say, oh, it's already there, sir, it was already there. So this is what it's important, always to write down the activity first and then the activity limitation. So activity is the person positive performance toward the task. For example, a person can feed himself at home, but feeding at restaurants or with groups, it's not look feasible because it's maybe a time factor. It's maybe some kind of pattern he's feeding, like if I'm mashing everything or I'm just taking, and but I'm independent, but that's look more that's not look good when I'm in some restaurant or whenever we are sitting in group. Outcome measures for both the adults and children are being designed specifically, and always the activity limitation is toward the difficulties, what he is not able to write. So for example, he can sit with minimum support. And what about the activity limitation? He can't sit independently. That's what we are writing. We are not, we in these two sentences, like if I'm writing, he can sit with maximum support, or in next activity limitation, if I'm writing, he can't sit independently. But if I'm giving you this format first, that if I'm writing and giving to you that this is the child, he can't sit, then you will imagine he's bedridden, he's only on the bed. But if I'm writing, he can sit with maximum support. At least whenever I will like send that patient to you, you can understand that at least if I will give him some support, or if the parents are there, at least he can sit. So that's how this is very important, the activity and activity limitation. So the activity may be some kind of functional part, like it's may related with the bed mobility, he can sit, he can turn. It's maybe related with the household activities, like kind of bathing, the self-care, actually the ADL's part. It's maybe kind of running, jumping, whatever related with that particular person, it's called activity. And whatever he can't perform, it's called activity limitation. What about the participation and participation restriction? That is also very important because these are our outcome related with the therapy. I'm so sorry. Actually, I don't know why, but there are many lines are coming on the screen. It's related with, I think someone is using some pen or something. I'm not very used to with this particular app. but it's really disturbing somewhere to me because I always want a flow to talk. And it's my request, if someone know how we can manage this thing, so please. So the next part of ICF, it's the participation and participation restriction. Participation, it's more about the social scenario. It's maybe related with therapy center. It's may related with the schools. It's may related with some kind of birthday parties. It's may related with mall. It's may related with garden. So participation always reflect a person function involved in life situation or the social situation. What about the participation restriction? It's about what he's not able to do that. So like imagine if I'm writing for a child and I will write down that he is not going to school or he's not able to go to school. And if I'm writing, he can sit inside the classroom, but he can't speak or he can't communicate with the teacher. So the two pictures are totally different. I'm giving you some positive aspect also, what he can do, how we can start our treatment, how we can give them a motivation. Yes, he can sit in the classroom. We need some modification. We need some communication devices so that he can carry on. So participation include how the person function is multiple environment or the social part. Participation usually involve other people. It's based on person value like me or the others. So like if I'm sitting in a classroom or in this meeting, if I'm talking, what's my value, what's my place in that particular group. So for example, a child who can clap, like whenever he's clapping at the home, but whenever we are in some parties or kind of birthday parties, he's not on time, he's not able to perform that. So definitely the participation and the activity parts is different. So whenever we are going to write down about the assessment part, definitely we have to consider somewhere the activity limitation, the participation and participation restriction. So these two parameters are very, very important for writing about any patient in terms of cerebral palsy assessment. Why it is important? Because these are the factor which is going to be changed with time. Like if imagine a child, he's able to sit with maximum support. So maximum support become my parameter that with therapy, definitely already he's sitting, but the time when he came to me in my clinic, he was sitting with maximum support. But now he can sit with minimum support, or maybe in future he can sit with supervision or maybe with verbal commands. So like, okay, sit straight, tall, look up, that kind of verbal guidance may be helpful for the kids who was sitting with maximum support. So these are the parameters which are very, very important. If we don't know about the scales, if we don't know about the specific thing, the ICF itself tell about so many things. So we have to consider. So I think whoever is listening me, whoever is attending this webinar, each and everyone has treated somewhere in life the cases related with the cerebral palsy. So just imagine one child in your brain and your image, and just think about the activity limitation, participation and participation restriction. Definitely you can write down very easily about that particular child. Even this is the assessment which you can write down in your exams, or if students are involved, definitely this is the best thing which you can take over with your writing work, and you can use it in any case, like it's maybe ortho, neuro, cardio, any case, because the ICF talk about everyone. So I hope this one is clear, the activity and activity limitation, the participation and participation restriction, because these parameters are very, very important for my future, for the kids' future actually, how we can correlate, how I can write down the first assessment and after 3 months. So whenever we talk about the social part or the participation, it's related with the school, it's related with the play with the friends, or it's related with some kind of birthday parties, it's may related with the outing, it's may related with the restaurants or somewhere the more people are present. It's may related with the personal relationship with the other, maybe with the friends or maybe with the siblings or in community. whenever we talk about contextual factors, I already explained you about this thing. The environmental factor, it's related with that particular scenario. The social, the physical, or may include some cultural barriers also, or the facilitator also. The personal factors, it's related with the age, lifestyles, habit, or the education part of that particular individual. Okay, so we'll go toward the our scale or the different scales I am going to talk. I hope I am on time. Uh, I think there are many professionals who are listening to me today. They are aware about GMFCS. It's very, very important. See, listen, I'm telling you again, and we all talking about the cerebral palsy because there are many scale which is only and only for the kids with cerebral palsy, like the GMFCS. Let's talk about functional movement. It's talk about the gross motor development. So whenever we are taking a child to consider in this particular scale, so just a minute. So whenever we are talking about different scales, definitely the GMFCS, which is like very useful, it's a research base, very valid and reliable also. Many people know about this particular scales. And is it visible now? Is it visible? So
Yes.
GMFCS is talk about only and only the functional classification. It's more talk about the pattern of walking. There are
Visible, sir.
lots and lots of description is there in this particular scales. So maybe in our WhatsApp group, if someone really need this particular PDF, I will share there. But I just want you to know how to classify what's the parameter. So even this can be useful like around the 2 years of life, then in between the 2 to 4 years of life, then 4 to 6 years of life, and finally at the age of 6 years, the functional level, it's almost throughout the life, it's not going to be changed. So what this particular scale is talking about? It's talking about how the child is walking in that particular scenario. So like level one. So level one is mostly talking about the independency, like they can walk anywhere. Like why I'm talking anywhere? So like imagine if a child is walking inside the house or maybe in our clinic without any support or maybe independent. But what about the outside? That also we have to be considered before classify any child. So if it is a GMFCS level one, then that particular child has to be independent in all the scenarios, means maybe for the activity also and for the participation also. So the child can walk without any limitations, means he's totally independent in level one. What about the level two? Level two, it's talk about walks with limitation. What does it mean? It means maybe inside the house or inside our clinics or the known environment, he can be independent in terms of walking. But whenever he's outside, like maybe in school, maybe in somewhere in mall or market, he needs some kind of finger holding or the holding a finger of mother, or maybe he needs the rail support at the time of climbing up down. He may needs some kind of sticks or anything, but that's in community level or and the social level. What about the level three? They may be using like they can move like holding the furnitures, or holding wall, or taking the support from the wall, and they can move from one room to the washroom to the kitchen. But outside, definitely they need some mobility devices, maybe the walker, maybe the frames, maybe the elbow crutches, any kind of devices. The level 4, they have some different kind of presentation. Actually, they are good in, not good, but they need some support even for the transition. So like, if they want to be go from bed to wheelchair, or they want to shift from one chair to another, even for the transition they need support. And outside, definitely they are wheelchair bound. They may manipulate wheelchair in some limited situations, but for long distance mobility, they need power mobility wheelchair, or someone has to use, because it's depend on hand function also, and the endurance. The level 5, it's totally dependent even for the transitions, for the within the house, outside of the house, everything they needs maximum support. So there's some difference actually. Why it's important? Because there is no confusion in between level 1 and level 5, but there is something confusion in between, whether it is level 1 or level 2, whether it is level 2 or 3, because it's look like similar within the scenario. Like if I'm talking about level 1 and level 2, the level 1 can walk anywhere, like in house or outside the house, or maybe in community. Maybe they need little more time, or the pattern of walking is somewhere different. But uh, it's not visible scale. uh, is it visible, the PDF which I'm showing you, or the scale?
Yes.
Okay. I'm showing something else. It's about the distinction, how we can distinguish. And whenever we are talking about GMFCS, definitely we have to wait for certain age, unless and until. That's how we always believe that early intervention program always help kids how to walk. Because if you can change in between some time, but at the age of 6 or 7, if I'm going to say to the parents that after this surgery or after therapy, if this GMFCS level is going to change, believe me, it's very difficult, and it's not going to be. So just imagine if a child is around 7 or 8 on a wheelchair, and we are planning for some kind of surgeries or a therapy program, definitely the GMFCS level in this particular age is not going to be changed. And this is somewhere like, if imagine if I'm giving you an assessment and I have written that GMFCS level is 3, then I'm not going to write down each and everything about that child, because GMFCS level 3 itself explain that particular child needs support outside, and even at home or within the house, he's walking with using some kind of support of furniture, or maybe some kind of hand mobility devices also. So it's depend on age, but we have to wait before be very sure about the GMFCS levels, that the age that is around after 5 years or around 6 years, everything is going to be very clear. I hope it is clear about the presentation. Like if I'm showing to you a video after this presentation, and I will ask you what GMFCS level is, then it's maybe 1 or 2 and 3. That's if I'm going, this is a child with GMFCS 3. I'm not going to give you all explanation that he can do this, he can't. GMFCS level 3 itself saying that outside or within the school or in somewhere of social function, he needs some support related with his mobility devices. Is it clear now? So I'm going toward the next thing. So GMFCS, let's talk about that. If I'm talking about GMFCS level 1, he is independent with even and uneven surfaces. GMFCS 2 level, it's more about that he needs some support whenever it's uneven surfaces, like some kind of going up and down, and maybe some marketplaces where lots of crowd are there. And in GMFCS level 3, they need some kind of mobility devices, and for long distance also they need wheelchairs for transfer from one place to another. GMFCS level 4, they can within the household, or maybe like from car parking toward the lift, they can move with their mobility devices, with even the manual support is required along with the device support. And in level 5, they are all dependent, even for a short distance, they need maximum things. So what's the difference between level 4 and level 5? I think the transference or the transition part is little bit easier as compared to the level 5. And I will share that PDF related with all the scale, which is there in, I will share it tonight in our WhatsApp group. Okay, so related with the next scale. So the next one, it's talking about manual ability classification system, MAC. I hope GMFCS is a little bit clear. It's long and long descriptions is there. You can go through that PDF, you can read it about it. And if any doubt, you can share in WhatsApp, or maybe you can ask whenever you want to know. So manual ability, or the MAC, actually what we call it, MAC. MAC, it's talk about the hand function. So we are talking, I'm all talking about the kids with cerebral palsy. I'm again and again saying this thing because these are the scale which are useful for the population who are diagnosed with the kids with cerebral palsy. So manual ability classification system, it's talk about hand function. It can be useful for any age, or like 4 to 18 years of age, we can use this scale. What is there in this particular scale? There are also 5 grades, like 1, 2, 3, 4, 5. What's the difference? Why 1 and why 2, why 3, why 4? What's the difference? So in 1, definitely the kids can use any kind of object or manipulate any object with both the hands, or like what we are using to do that. So handle object easily, and even they can finish their task. What about the 2? They can manage, but the quality or the pattern is something different. So just imagine if I'm visible to all of you, then if I'm holding this bottle, and is it visible?
Yeah.
So if I'm holding this bottle and I am level 1, so yes, definitely it's need little bit more force, or may take little more time, but I can open it. If it is level 2, then definitely I need little bit more support with my trunk, or maybe I'm using some accessory movements, but still I can manage, or may need more time. What about the level 3? Level 3, it's talking about the difficulties. So like if someone going to hold this bottle for me, and then, or maybe if I can hold this bottle, or someone is just taking a part, or someone can open this cap for me, then I can hold and I can drink. So it's look like some part a person can perform, and some part the other person or may need help to prepare that particular activity. What about the level 4? Level 4 is talking about they can use some object, like we are using it OT, like the some kind of adaptive devices, the big handle cups or the spoon with wider grip. So they can use, but with limited objects only, or they have their own adaptive equipment, then only they can use. They can't use the generalized things. What about the level 5? Level 5, it's something like if I'm just using my head for some kind of communication, like bye-bye, or maybe yes or no kind of things, but there's no functional performance in that particular child. So if I'm writing down a case of GMFCS level 3 and MAC level 2, so I think I'm very much explanatory in that particular thing. If I'm writing that this child is having GMFCS level 3, then definitely I know in community he needs support, maybe the walker, maybe the crutches or anything. And if I'm saying this child is having MAC 2, then definitely he needs extra time to perform that particular task. So I think now I am very clear in terms of writing down. So in my assessment, first I will write down about the ICF, the whole ICF. What about the activity limitation, the participation restriction? Then I will think about this particular child before commenting on the functional level. GMFCS is talk about the walking status, or how he's walking in society, or maybe in our known areas, and how he's using his hand for what purpose. So if it is 1, 2, 3, 4, 5, there is no functional performance, but yes, they can use it for some kind of yes, no, or maybe kind of some kind of action. So again, I'm showing you how it's just give me a minute. This particular scale is also very much explanatory how it is important, what kind of objects they can manipulate, and also this page, particularly this page, it's very important to read related with its all description. So if I'm talking about what's the difference between level 1 and level 2, definitely we have to be understand in level 2 the performance of same activity which a child with level 1 can do, but the quality or the time it's more, or the performance is very slower if it is a child with level 2. In level 2 and level 3, definitely level 3 is talk about some part I will do my own, and some part the mother has or the caretaker has to perform. So like imagine if I am having my own plate for my meal, and I am very much independent to finish my meal. And if someone just using or taking more time just to take the food in a spoon and toward the mouth, definitely it's going toward the level 2. And if someone is neat, someone has to be mixed that dal chawal or maybe some kind of breaking that roti or chapati in pieces, that's the preparatory part. That child can't do that with their own hands. And level 4, they are only having some kind of, like, if I'm just rolling the chapati and giving them, they may be some kind of accessory movement and they can take big bites, but it's very difficult for them to use any kind of fine activities. And level 5, they can't functional actually in terms of their hand movements. So we'll share this particular PDF. Okay. The next scale, the Communication Functional Classification System for Individual, or we call it CFCS. This is also very important because why it is important? This particular scale is talks so many things about in terms of the communication part, how child is talking about to the other person, or how this scale is useful to know about the child communication level. So this particular scale, okay, is it visible? This one, this PDF, is it visible? So,
Yes,
so like this scale is particularly, again, the level is 1, 2, 3, 4, and 5. So just go toward this part where there is a one square with P, one circle with U, one square with F, and that's how we describe. So just imagine this P is that particular person or the person with CP. This U is for the unfamiliar partner or the unfamiliar person who is new to that particular person. And this F is about the known or the familiar person. So the level 1, it's about two-way communication with both the people who are very known to me or the people who are just new for me. So that is called the effective sender and effective receiver. So I can receive what you are talking and you can receive what I am talking, but it may need little bit more time. It may need more clarification in terms of my sound. Like if I'm asking you, what's your name? Then they may need, what's your name? So that may be possible if it is level 1 and level 2. Level 1. In level 2, this red arrow, it's showing that with unfamiliar person or with new person, they need time. So sometime in therapy centers, the mother or the caretaker, they understand very easily, and then will ask, okay, mom, what he's saying? So then they said, oh, he's talking about this particular thing. So because they can understand within one word or two words what he's talking about. And here we need all explanation, that what's your name, where do you live, everything they can explain. But in this thing, they are very used to, or they are very known, or the tone or the voice or the communication skill is very known for the familiar person. So that's how they understand. And even they people, like the people with cerebral palsy, they also understand what they are talking about, the familiar person, what they are talking about, because they are very used to with them. But the unfamiliar, it's take more time or more communication clarification they need. What about level 3? Level 3, it's all talk about that they are effective sender and receiver only and only with the known people or the familiar people. What about level 4? Even with the familiar people, they needs more time, or only they can understand few words. only few, or they are not actually good receivers and good sender also. So it's kind of do you have your meal, they will say that kind of communication, and even only the familiar person can understand what they want to say. And in level 5, definitely seldom effective sender and receiver even with the familiar person. So they have very limited, or maybe some kind of sound, or maybe some kind of particular sound. So that's how the parents or the mother can understand. If he's creating this sound, maybe he's indicating for the toilet or potty or something kind of this thing. So just imagine if I'm writing down of a child, and if I will write down in my assessment GMFCS2, FCS2, and MAC 3. So definitely I'm not giving to give you all the explanation. I will just write down the GMFCS2 means he is independent on even surface, but on uneven surface, he needs some support or extra help. If I'm talking about MAC 3, definitely I need some part someone has to do for me. If I'm talking about CFCS level 2, definitely I'm very, very good in terms of communication, but I need some extra time to understand or to communicate with the unfamiliar person. I hope I am very clear in these 3 scales. There's one more scale which is about the functional mobility. This one is also talk about the gait or the way or the distance. Actually, this scale is mainly talking about the distance, how long that particular child can walk. So in this particular scale, they are talking about 3 parameters. So they're talking about 5 meter, they're talking about 50 and 500 meters. So how we can talk every time we don't have that space that we are going to measure these things. There are 3 questions which we usually talk. How your child is move around for the short distance, or maybe within house, how he is walking. Or the second question for 50 meter, we usually ask how your child is moving within the school, or maybe from one class to another class. And the 500 meter, we always ask about how does your child move from long distance, maybe in shopping centers or maybe some kind of garden or something. So just imagine if my first question is, how does your child move around in short distance? And if you are saying he's independent, like for short distance, for 5 meter, he's independent or he's not needing any support, then I will give him number 6 or the score 6. And for the second question, if they are giving answer, how does your child moves around in between classes or in like from one class to another class? If they are giving, he needs some support, maybe the wall support or maybe the crutches, I give him number 4. And in 500 meter, if they are talking about he needs wheelchair, definitely I will give him number 1. So this is how this example is given. If a child is walk independently at home on all the surfaces, but uses crutch in school, playground, and a wheelchair, maybe for airport or something like that, then they have mentioned it's 631. That's the score for FMS. That is, he is totally independent for short distance. For 50 or maybe limited scenario in our society, he needs support, and for long distance walking or transport, he needs wheelchair. So they have given the number 631. So I will share this particular scale also in our WhatsApp group. So you just go through it. There are good example which is mentioned here, and they have given them the score also. And you, once you read it, you will be more clear what they are talking about. The next, what's the time? Okay, so just last thing, actually, I know I am over this particular time. Actually, this is my assessment sheet. I'm going to show you one sample how we can write. So like these are some common format which we have designed actually in our clinic, how we can write down for a patient with cerebral palsy. So definitely the common is demographic data, which is related with the name, age, sex, everything. What about the general observation? General observation is always talking about how the child is coming to your center or enter in your center, whether it's on wheelchair, how he is cognitively, he's happy, he's looking at you or he's not looking, he's interested with the toys or he's not he's looking toward the environment of that particular thing or not. It's about the general observation. What about the emotional stat, attempt to communication, everything? It's related with his higher function. Actually, we are talking about. Then the birth history, which is very very important. Then the last line, which is talking about functional ability, it's more about the activity and activity limitation, which we have to write down. The functional limitation, and that's what he can't do. I already explained it. Participation, that what he can. I always write down the positive part first and then the limitation. Contextual factor, this all I'm talking about the ICF. Then we have to write down about the multi-system impairment, which I will more explain you tomorrow when I will be in lab. So we have to always write down, if I am assessing a child either in lying down position, in sitting or in standing, whatever you are doing, you have to check for alignment, the symmetry, the stability, the posture, dissociation. Dissociation may be the interlimb or intralimb, how he is walking, the weight shifts, and the atypical movement pattern. Next is about single system, because whenever we are checking, like it's may include the musculoskeletal, neuromotor, sensory system, respiratory system, and the last but not the least is about the summary or the plan of care. Then our goal, because the therapy is always goal oriented. So what's your therapy short term goal, long term goal, and recommendation, which is always important. If I want to refer this child to, or I really need some suggestion from some other professional, then definitely we need to write down some recommendation. Just last thing, I'm going to show you one sample how we can write down, although it's a patient assessment, but still I want to show you how we are writing down so that you can be very aware about how we can write down. So this is a presentation related with a child who is diagnosed with developmental delay, but definitely in terms of GMFCS, I know this child is going to be developed the presentation of GMFCS. That's different. I can't explain that thing presently, but I'm writing this assessment for a child who is 8 months old. So this one assessment of last year actually. So I have written about birth history, and then I have written about medications. But for more important in terms of today webinar, this is how we have to write down. So although I'm writing for a 8-month baby, but definitely we need to write in the same way. So if I'm talking about the functional activity, that's how he's doing. So I have written earth can sit with minimum support. That's how my parameters are. We are always talking about the positive fast first. So earth can sit with minimum support in ring sitting position, like holding a ring or sometimes hand over the bench. This PDF is visible?
Yes, sir.
Okay, thank you. Earth can sit with back support and can use his hand left more than right independently. So everything I'm writing positive way, what he can do, but he needs support. Earth can turn to sideline, can come to supine to prone, prone to supine also. When he is on his tummy, try to push by his leg and move forward. So these are some positive aspect which is there. Definitely they need that support, or we need that explanation. He's doing something. Even if it is a case of GMFCS level 5, who is totally wheelchair dependent, believe me, I am going to write about the functional ability. That is the positive part, what he or she can do. Either it's with maximum support or with minimum support, everything I'm going to write. So related with fine motor activities, earth can hold the object with crude grasp, like this. And even he can use both the hands, he holds toy, everything I have mentioned. In ADLs, actually, because he's around 8 months, so everything is dependent on the mother. But what about the environment, whether he is looking down or he's searching for the mother, or he can understand, that is also the part. That's what I have mentioned in communication, how he's communicating. The earth can produce sound, oh, when he looks toward the screen, maybe like, actually it's related with a particular rhyme. That's how he's producing oh. And also he can communicate with mother, producing some sound, mama, that kind of sounds. But he also tries to imitate, but sound is not there, only the lip part or the facial gesture is somewhere there. What about the limitation? Definitely, as we are writing for the 8 months old baby, so we can't write down he's not walking, he's not standing, because that's not the 8 months functional thing. So what we have written he is not able to sit independently, he's not able to creep. That's how the age appropriate functional limitation. In participation, what about a child who is around 8 months? Definitely he needs a good social smile, so he can communicate with social smile and some kind of sound with the familiar person. What about the restriction? Restriction is not very interested in terms of toys and exploration, because this is the age when kids want everything in the mouth, or he want to hold each and everything. That's the limitation. Multi-system assessment, actually we need to observe. So like if he's sitting with a slouch position, definitely everything I have to mention about this particular child. So he prefer low center of mass, narrow base of support. He has sagittal plane of movement, means more kind of trunk flexion, and it's difficult for him to go away from the midline. We'll explain you tomorrow in lab session. And single system, we have to write down each and everything about the musculoskeletal system, that is where is tight, where is the contracture, how many muscles are tight, what about the tardive, what about the max scale, and everything we have to write. In neuromotor status, actually we are writing which muscle is overfiring, which muscle is over recruiting, where is poor balance in between, which muscle is having concentric muscle work, which muscle is not able to perform eccentric. That's what we have to writing. And definitely at the end, I have written the session goal as well as for the short term and long term goal. So for 8 months old baby, where I know all my limitation also. So what I have written for short term goal, earth will sit. So in goal, always a function has to come first. So like sitting is a function. That's how in ICF I told you, the ICF, it's all talk about the activity and participation, and goal always have that particular thing, like the either activity or participation. If there is no activity, no participation in our goal, definitely that's not going to work, because that's how we have to write down the goal for any child who is having any kind of developmental issues, either a CP or genetic disorder or the autism. So what I have written, earth will sit in 90-90 position with minimum support at shoulder and with back support, and play with cause and effect toys. Cause and effect toys is if I'm pressing particular button, it's producing a sound, or some time of if I'm tapping, because we have to consider everything, the age, the scenario, and it should be a realistic. The goal always should be realistic. I can't write down that he will sit independently in short-term goal, because it's need time and long therapy. With back support and play with the cause and effect toys, which is over the bench, keeping in front of him. How he is playing, how he is holding, how much support he needs. Everything has to be there in our goal as a parameter. And then try to the toy 3 out of 5 times by looking toward it. So that my parameter is sit. How he is sitting, 90-90. How he is sitting with minimum support. Where is the support? Shoulder and back support. What he is doing, he is playing. How he is playing, he is playing with a toy which is on the bench. It's not on the floor, because I need range, I need posture. And second goal, which I thought it's in terms of his communication, in terms of his participation, earth will sit in high chair and look toward the mama or mom during the time of feeding, and assist his mom for feeding with response of sound of cooing. That is age appropriate, that's come around 7 or 8 months. Long-term goal, definitely earth will sit independently in 90-90 and play with toy with his friend or caretaker. Maybe if one child is sitting in front of me and I'm just saying, okay, take this, give to me, that kind of interaction will be there in terms of my long-term goal. Because the short-term goal and long-term goal always has to be connected in my assessment. If I am saying in my short-term goal, he will sit with minimum support, and in long-term goal, I am talking about the walking or running, definitely it's not going to work, because long-term goal, it's around 3 months, 3 to 5 months we have to work for. And short-term goal, we are talking within the 3 months. And even we are writing sometime session goal also. So these are the parameter which we have to consider. Whenever we are talking about therapy or these kind of things, we always have to consider the activity limitation, participation and participation restriction, and either the activity or the participation has to come in our goal to explain. So if someone is asking, if some neurologist or some doctors who may be there in our webinar, and if they are asking why you are working for, definitely this my goal is talking about where is the minimum support, how he's sitting, how he will do. So this is one activity, but for this particular activity, I have written why he's not performing, what's the problem, which muscle is over recruiting, which muscle is not coming to function, what about his arousal, what about his sensory part, what about his restrictions, everything I have mentioned in this particular. Although why I am explaining this 8 months baby assessment, because that's young baby to writing something, it's very difficult, but for a child in around 6 or 7 years, at least we can consider some part in terms of sitting, in terms of our functional status, the talking or maybe walking, everything. But for the young kids, but the reason behind this particular presentation, it's all about whether a child of GMFCS5 who is totally dependent, we always have to write down the ICF part and our this kind of format, the scale, which scale or the which grade of that particular scale. So actually this is the topic which needs maybe 1 day or 2 day full day workshop to explain each and everything, but I try my best to give you insight how we can connect the different pieces of assessment and write it down in our documentation. Tomorrow I will teach you related with the techniques, the basic part. I'm not going to show you anything on my laptop, but everything will be as a live demo tomorrow in our lab. The basic therapies or the treatment modality, there are many things which is available, but the kids with CP, they needs medications as well as therapy, and it's depend on age. I know it's beyond my time. I'm so sorry for that to the management, but as the topic is related with all assessment, I have to finish somewhere. Thank you so much. Thank you so much. If anyone have any doubt, anything, even they can ask in WhatsApp related with that thing. I will try to give my answer because we are already running late to the time. And tomorrow, I request we'll start exactly at 3, and then I will show you the basic technique. Please, everyone be there so that you can learn some basic concept behind the treatment. Thank you so much.
Thank you so much, sir. Now, I would like to invite Dr. Ligi Martina ma'am, Assistant Professor of Neuro Department, Nanda College of Physiotherapy, to deliver the vote of thanks.
Good evening all. It is my privilege to have been asked to propose a vote of thanks on this occasion. I would like to thank our chief guest, Mr. Abid Barura, for making an excellent presentation and making the webinar interesting and meaningful. I would like to express my gratitude to our principal, Mr. Manivannan, for providing encouragement and support. I would also like to thank our HOD, Mrs. Chitra Devi, for her moral support and guidance. I am happy to express thanks to our staff members who have made this today's section grand success. Finally, the wonderful students who have turned up in such a great members, not only from our college, but also from other college. Thank you so much for your cooperation. I, on behalf of Neuro Department, extend a very hearty welcome you all for the continuation of tomorrow's section. Once again, I thank you all for your cordial cooperation. Thank you.
Thank you, everyone. Thank you so much.
Thank you, ma'am. Thank you all. Feedback form will be provided tomorrow 15 minutes before the session ends. We will meet again tomorrow at 3 p.m. I request everyone to join the webinar in time. Stay safe, stay strong. Happy evening, everyone. We all can leave the webinar.